My name is Bumi Mabuza. I'll be facilitating today's session. I would like us to introduce ourselves before we proceed. Just a quick introduction, your workstation, and your name. Then, if you have joined in a group like us here in our hub team, we will also introduce the person that we have joined with. I will start with my team this side. I have Mr. Seven Gambule and Messi Shabangu and Sibongile Simelane. Let me hand over to Specific.
Dr. Specific Lamini Manzini Government Hospital.
Thank you, Dr. Can I have Nana?
Good afternoon, team. This is Nana Chandu from the In-Service Department at Manzini Government Hospital.
Thank you very much. Can I have Visiwe?
Good afternoon, Fezwe Makubu from Nature Shiselweni. Thank you.
Visiwe, sorry. Okay. I would like us to proceed. On our last eco session, we were talking about court status discussion, which is focusing mainly on the emergent treatment a person would or will not receive during a life-threatening event to sustain life. Some of these treatment would be CPR, incubation, and ventilation. And this treatment, it's patient-centered, and it must involve also the family. And the life-sustaining treatment must be measured against the effect on quality of life of the patient. The desire for fluids and food decrease is a normal process when the body is shutting down. So this is what we discussed on our last session, on our last eco session, and there was a case from Babane, government palliative care, which was involving a patient with deep vein thrombosis, and the problem with this patient was that the caregiver is complaining that the morphine that is being administered to the patient, yes, it does the work to address the pain problem, but the patient is always drowsy. So here the caregiver asked to reduce the dose from 4 hourly to BD. The morphine dose from 4 hourly to BD. And we are going to carry on to today's agenda, which is transitioning to death. And we are going to have a presentation by Messi Shabangu, which entails communication strategies to end of life and the changes that occur during transitioning to death. I would like us to give Messi the floor and continue with our today's presentation. Thank you.
Thank you, Bonnie. Good afternoon, colleagues. My name is Messi Shabangu, as Bonnie has mentioned. So before I get into today's topic, I'm just going to quickly highlight that we have been treating the communication series, where we looked at a couple of topics. And in case you've missed some of those topics, you can actually visit our YouTube channel to be able to catch up and follow through on the topics that we have been discussing. We've looked at the core elements, where we looked at the skills that we can use to gather and give information as we engage with our clients. We looked at family meetings, how to conduct them, mistakes to avoid, who to invite into the family meeting. We also looked at breaking bad news, where we looked at the SPIKES protocol on how to actually break bad news. Then we moved to ongoing goals of care, where we looked at the systematic meetings that we can actually use to discuss the patient's concerns and focusing on the patient's priorities and the fact that the patient's needs do shift. We then moved to advanced care planning. And then in our last session, we were looking at code status discussions. So today we are looking at our last topic under the communication series, as I've mentioned before, which is communication during transition to death. So the objectives of this topic are to prepare healthcare workers to communicate effectively at end of life, to identify changes during the transition to death, to demonstrate understanding of the things to consider during communication at end of life, and to explain the communication strategies during transition to death. So when looking at transitioning to death, we should always remember that each person experiences the last few days of their life differently, and they each have different needs. Patients in their final days normally require exquisite symptom management, which is very important for the purpose of continuous improvement of quality of life, and for the client to be or to experience comfort and good death. It can be difficult to predict exactly what will happen or how quickly the changes will occur, because every condition is different and every client is different. So sometimes changes happen more quickly than expected. The thought of death nearing can be frightening both to the client and the family. And as much as we know that death is a normal process, it is important to understand that it's natural to worry about what will happen. So it is also necessary to master the palliative care skills in order to competently manage the dying patient, which is why we are treating today's topic. So there's usually changes during transition to death. Some of the physical changes that occur include distressing symptoms like breathlessness and incontinence, and skin sensitivity increases, where probably would recognize red or purple marks. In most cases, they actually develop at the feet and then they move upwards with the body. Also, still on the sensitivity of the skin, there's also issues of bed sores that we should be mindful of. And then oral intake actually reduces at this point, of which the client can have loss of appetite, which is anorexia, and loss of body mass. So these are normal things to occur when transitioning to death. And then other changes can include increase in anxiety and the fear of loneliness. For some clients, they might hallucinate, they can hear voices that other people cannot hear, see things that other people cannot see, or feel things that other people cannot feel or touch. And then there's also issues of agitation and restlessness, where the symptoms in this case may differ from one person to another, but there's usually turning and tossing with others. For others, there's angry outbursts or even accusations of wrongdoing. Now we are going to look at the two phases of dying. There's the pre-active phase of dying and the active phase of dying. With the pre-active phase of dying, it usually occurs 2 to 3 weeks prior to death. And the client may experience symptoms like the increase in periods of sleep and the loss of energy. The client might withdraw from social interactions. And there can be inability to heal from wounds or infections. And at a certain point, some clients start accepting that death is inevitable in that situation. And then there's the second phase, which is active phase of dying. It occurs 2 to 3 days prior to death. The client experiences symptoms like a reduction in oral intake and sudden change in vital signs like their temperature, their BP, and their respiration. The exact moment of death remains unpredictable, but being there allows you to offer your love, care, and support to the client and the family. There are things to consider during communication. One of the things to consider is family involvement when we are communicating at end of life. Family involvement requires that we conduct a family meeting where we can give information to the family members and the client about the condition and about what to expect at this point. And this is where we can also receive information from the client and the family members about what kind of care they want at this point. We are also able to identify the needs that the family and the client has in order for us to be able to support them. Another thing we should consider is to continuously consider the review of goals of care and to activate an advanced care planning if we haven't already started on that one. So we look at emergent treatments like artificial feeding and hydration preferences as discussed in our previous session. We also consider end-of-life issues which involve family grief. So we can look at issues of how the family is coping with the situation and how the client is actually coping with the situation as well. And then there's cultural issues and issues of spirituality that we also need to consider them when working with the client and the family, where we are able to identify their needs. In some cases, you might find that the client or the family members are anxious about the dying process, how it's going to happen, if the client will be in pain or not, whether the client will go after death or afterlife. Others are even concerned about regrets or arguments that they had in the past. So it is important that as we communicate with the client and family members, we consider such things. There is also issues of ethical dilemmas that could occur. An example could be withdrawal or withholding of fetal treatment. So we should consider that, and it is important that we use a team approach or involvement when working with the family to improve holistic care and support. There are communication strategies that we can use whilst communicating with the family and client. We can make use of physical presence and touch. These are important and they are an understandable mode of communication, but we should be mindful of cultural and gender issues in terms of physical touch. Another strategy we can use is we should allow the client and the family some time to spend together during the last moments and even after death. It is key to attend to the client's spiritual needs, as I've mentioned before. And if the need be, and also with the consent of the client, a spiritual leader can be involved. A prayer can be held and rituals can be performed. But of course, this has to happen at the consent or with the consent of the client. We also involve the client in the care until death, where we basically consistently promote client autonomy. And we should always remember that the client's sense of hearing is the last one to be lost. So whatever that we are doing with the client, we communicate with them or we involve them throughout the entire process until their last breath. Another important strategy can be our availability as a healthcare team to the family members and to the client for sharing of information, and for also showing empathy and support throughout the phases of death and even after death. It is also important to collaborate with the clinical team, which could involve a social worker, a spiritual leader, a doctor, and a nurse. We've come to the end of today's presentation. Thank you, colleagues. I don't know if there could be any questions.
Thank you very much, Mercy. I would like to give this opportunity to anyone who has some addition or concern or questions. I'll give you guys at least 5 minutes Then we will proceed to the next agenda. Thank you.
I would like to add a few things that we need to pick and understand with these patients who are at the point of death. Is the issue of anxiety. Normally, what happened is you will find that both the family, the patient, and the healthcare team will be engulfed by the anxiety, especially the fear of death. At the healthcare worker perspective, it would be the anxiety and fear of losing a precious soul, and the family of losing a loved one, and the patient being the anxiety and fear of losing control of the situation. And then there are issues of end-of-life visions and dreams, and then there's hallucinations. So there, the end-of-life visions and dreams are therapeutic and helpful for the patient. So we normally misinterpret those visions and dreams at end of life as hallucinations. You will find that a patient will say to you, yesterday at night, I was talking to my grandfather or my so-and-so sister who died some time ago, and we have a good moment. And I was very happy that he said, I'm welcome home. If then you are not sensitive enough to understand that, you will think the patient is hallucinating, having visual hallucinations or auditor. So yet such visions and dreams need to be further assessed. You will find that most of the time, the visions and dreams of end of life, they are therapeutic for the patient. The patient will understand them better, and they make sense to the patient, and they build the patient. And most of those visions, they connected with things with spiritualities. You will find that one will say, I saw Abraham saying this and this to me. Or else one will say, I've seen God. I saw heaven yesterday, and I don't feel like he is lost. Yet those things, when they are communicating them with us, they are very happy, and when we accept those things, and they be. There are those hallucinations when they will be talking things that are unheard, and then you will know now they are hallucinating. The things they don't make sense, and when you connect the points, they don't come up with what the patient is trying to say. And then there are other issues that sometimes happen at this end of life, especially during the changes. That sometimes lead to misunderstanding or conflicts. But I guess if we can adhere to the elements of communication, especially the goal setting and advanced care planning, we can address such issues, especially patients who are at this stage of death. The last 2 weeks or so, they will present with the reduced oral intake. Normally, they will be not eating, and you will find that most of the cases, they will be admitted into wards, and doctors will put NG tube and remove NG tube. Or else they will be presenting at our emergency room, OPDs, and with dehydration and stuff. And then we will find that we will be rushing to rehydrate them or put NG tube. And then yet at this point in time, physiologically, you will find that they will present with the Kaiexin. And normally the Kaiexin they present with is related to the diagnosis or the condition itself. So it is very important at this point in time that either communication or decision that could have been taken will be influenced by the goals of care, patient autonomy, and the ethics themselves. Because it won't be beneficial to feed such a patient another 2 weeks to live, and then you think you'll revive that patient with food. And normally their gastric system is no longer effective. The motility is no longer there. So if you feed such patients, they will then end up dying. So those are things that I will add to these issues. And the other thing I need to understand that unfortunately we cannot predict when a patient is going to die. You cannot say that now he is going to die, but there are things that you may see, like the fluctuation of vital signs. That you take them in the morning, they were normal, but now they are down or they shoot up. So those are may help us. But what is very important then is to be there as a presence, like in statue, be available. You know, sometimes you feel like you need to run away, not be there in presence, but your presence as a healthcare worker is very important. And the presence of the family members is very important. This is not the moment we will take them away. This is not the moment we will move away from the patient. But when the patient is approaching death, some of the patients will verbally call you as a healthcare worker to be closer, but some will not. So it is very important that you are there in your presence, emotional, psychological, spiritual support. Even the family members, if they are there, you will find that in the world, maybe they will take them out because they want to do ABC on the patient. But this is the moment we need to allow them to be close with the patient. That's the mode of communication this patient is understanding and is able to interpret very well. Another thing is that the words we say, they are very important to the family and the patient himself. Anything you say to a dying patient, it sticks to the patient and he gets what you are saying. So it's very important that you don't force things to the patient, but whatever you are going to do, whether you're going to tell the patient, whether you're going to do something, say it, even if the patient is not going to respond. It's still important that you say, oh, we are going to change you now to this side. He will understand what you are saying and he will appreciate that. Remember, these beings are spirituals, and so the presence. Some will request their spiritual persons to come, even if they are not going to say a thing, maybe, but the presence of their spiritual beings, either a pastor or so, such communication is very important. I will stress to say, at this point in time, we will find that now we are relying on what we've been discussing with the patient in the past to make the decision. But the visions and dreams, they are so therapeutic to them. They help them to cope with the dying phases. The family involvement, being present, close to the dying patient, also those ones, they are so therapeutic to them. Even if the decision to make some intervention, need to be cautious. Don't push things to the patient that will not benefit them. While also, let's continue to involve them as I've been doing while they're still able to talk. I will add that only. I'm seeing a question here that says, thank you too. Was wondering what are the most common scenarios that happen at end of life. So I think the team and the colleagues online can share the experiences that they have seen, the scenarios they've experienced, and then I don't know if they can through the facilitator.
Thank you for the question. As Mr. Mahlame has mentioned, anyone who wants to say something about the consent on the changes that occurs during end of life is free. You can raise your hand or you can type on the chat box. We will then read from the chat box. Oh, thank you. Seven here wants to say something. Over to you, Solomon.
Thank you, Mr. Barbosa. Afternoon, colleagues. Well, one of the scenarios that occurred during death, actually, you usually find that most of the patients they experience gasping, which is something that it does happen with some of the patients. It's one thing that I can share, especially the moments before that, few minutes before he dies, usually gasp. Some experience that. Maybe my colleagues will also share their other experiences. Thank you.
Yes, I may wish to add something that we have experienced with the organization. In the past months, we have had a patient who was at this phase of death. What happened is the patient called the nurse, is our patient in the home-based unit around Manzini. He called the office and called the nurse who usually visits her at home. When she called, she was complaining of severe pain. So what happened is, and then the nurse, as usual, released a staff member to go and bring the medical supplies for the patient. So when the staff member arrived at home, when the patient was informed that the organization has arrived and that means the medication was available, the patient then died. And the complaint was that the patient was complaining of the pain and saying it was severe. So that was the worst experience we could have as an organization, that you know, at the end of life, some of the things that will come is the worsening of pain. So the patient will die, will complain of pain, and the family members had nothing to help. Unfortunately, we don't know what was aggravating the pain, because the reality, the patient was already living. So in that cry and complaint of pain, the patient just died. So you may have all such things happening to patients. So it's very important that the family involvement is critical and all plans are thrown into place before the worst may happen, and the proper management that promotes comfort is provided at this end. I may share that also, that we have seen happening with our patients.
Thank you, Mr. Mashangu. Anyone else? We will continue. You can raise your hand or share in the chat box. And what I'm picking from the speakers, from the previous speakers, is true, as in our introduction is mentioned, that each person experiences these changes differently. Some they may go very nice and quietly, and some they may want their close relative holding their hands and they go very peacefully. So it's very much different. It depends on that individual. And I have a question on the chat box, which specific spiritual prayer should healthcare workers know or do for the patient to pass on in peace? I would like to invite Mr. Mercy for this one to take it. Thank you.
Thank you, Bonnie. Thank you, Patsy, for the question. I think my colleagues will help you on this one. I don't think there's a specific spiritual prayer that we should know as health workers The kind of prayer that the client might need at end of life depends on their religious affiliation, which the religion does the client affiliate with. So if the client, for example, is a Christian and you're also a Christian, it would be easier to pray together in a situation like that. But if the client has a different public belief system, you could find out from the client if there's anyone that they would like to come and pray with them. It could be their pastor or any spiritual leader that you can get.
Yes, did you get that, President?
Another thing we need to understand about the spirituality during the end of life. As a healthcare worker, you may not be comfortable with prayers. For example, if you're a Christian, a Muslim is in the building. You know, I understand sometimes I will make an example of Roman Catholics. You will find that there's this unleavened bread. So some patients, you will find that they are devoted Roman Catholics. And if now they can tell that I'm going, they will request either the bishop to come and render the unleavened bread to them. So Labanye you will hear them say, maybe I want a good and then you'll feel like they are hallucinating. Yet to them, maybe it's what connects them to their eternity that they are going to. Someone will say, I want my little here or a certain thing that I left at home, because they say now that they are going. So your duty as a healthcare worker now is to understand the spirituality part of the patient. Even if sometimes the relative will come in the ward, if it's in the ward, especially, or it's a home, and then they have different spiritualities. Then your duty as a healthcare worker there is it will be to understand the spirituality of the patient and the family and find the common ground. If then it's against the patient will, you will find a way to help them to find a way to pray in a way that will comfort the patient, because sometimes that's what happens at the end. Sometimes the spirituality will be the issue of being connected to a person. You will find the patient will be calling you now and then. You are living, the patient is calling you nurse or doctor. If you are gone, then he calls you again. He just wants to die in the hands of someone else. That to him will be a complete issue. So you will find, so it's very important then to be aware of your own spirituality, because some people will say, if a person dies in your hands, now to fully cleansing, you see. So I in my head. So those things, so we need to be aware. That's why at this point in time, the presence issue makes a lot of needs.
Thank you, Mr. Mashano. I see Sister Felicity up on the chat box. I will read as is. There is a rise in children with cancer and they die without their wish and once not met. Hence, we need to have skill to address them too. I hope everyone got what I said. If you didn't, you try to go back to the chat box. But if anyone on the floor and in my team here has something to say about our concerns about children dying without their wishes being met, can say something. Anyway.
That one is true. We had a patient with around the Lobamba Zubiri corridor who was from Wogo region. This child was bedridden and then was placed on NG tube at end of life. So I think it was the issue of that now he has been in this chronic illness for some time, but in the last 2 to 3 weeks of his end of life, the patient then shut down eating. This child stops eating. After he has stopped eating, then the parents take the patient to hospital for artificial feeding. And then the child removed the empty tube. So what was happening is when the child has removed the empty tube, they used to find ways to that it can be put back again, and the child will continually remove. Because now the child was unable to say that he don't want the empty tube, but he was showing it out that I don't want this. And a few days down the line, the patient died. Can you imagine dying with an empty tube in your nose? How painful it is. So we stay low in the care of the system to do good communication before these worst scenarios happen. So then we subject them to such issues whereby they cannot say a thing. But if we have time when they were still able with the chronic or the life-limiting illness, when they could speak or share their wishes, we could achieve a lot as healthcare workers. So I think the issue of communication also helps a lot.
Okay, thank you, Mr. Mashamu. I see this saying it's true. Okay, thank you very much. And now I think if anyone else has any concern, we'll move on to our next agenda, which is a case presentation for the day. But you can still write your question on the chat box. For time's sake, we'll move on to the case presentation presented by Sebenele. Yes, he's ready. Let's give the floor to Sebenele to present a case for today's session.
Thank you so much, Mr. Mabuza. Good afternoon, once again, colleagues. It's a good day today. I hope everyone is okay. So I'll be sharing here a case it's a follow-up case actually for a 63-year-old female diagnosed with cervical cancer, which is at an advanced stage. The problem with the client is that the patient is at end of life stage of disease, and her personality status is ECOG-4, meaning that is totally confined to bed. Okay, her general condition is clinically unstable. He's an unstable patient, and he has been hospitalized 4 times this month. So the concern is the patient has accepted that he's at end of life stage. He has accepted that he will die actually. But some of the family members still believe he can be treated traditionally, but it's against the will of the patient. The patient is against that. So the shift complaints. Okay, the patient complained of moderate to severe back pains for the past 3 weeks. Loss of appetite in the past 5 days. Fatigue for the past week, mild to moderate constipation the past 4 days or 4 days ago. Then, okay, the patient assumed one position unless he's stand by the caregiver. So he's actually dependent on the family members to assist him with activities of daily living, and he also complained of shortage of food. And the medical or surgical history. Medical history is that the patient, okay, he once received chemotherapy in clinic last year in June, but he was then stopped. Okay, from taking another cycle. They say HP was low. He was awaiting blood transfusion, but he ended up not getting I think he didn't get the donor, blood donor. Also called, okay, he also did a scan, I think in August last year. And the results from the scan, okay, indicated that, okay, the cancer has progressed. So under medications, okay, only did the chemo, that's the information we got from the patients. Currently, when we last visited the patient, she was on liquid morphine, 3 meals PO, 6 hourly. Was also taking ferrous sulfate and folic acid. He's also on ART. Okay, and the social history. Okay, the patient is a self-employed patient. She's a farmer actually, but due to the illness, no longer gets income, okay, except for the elderly grants from the government. Okay, okay, he last did high school education. He's of middle class, socio-economic class. He's a widow, and there are no harmful habits reported, and also he's unaware of any health condition in her family. Then under advanced directives, orders, okay, there were no orders to end DNR, do not resuscitate orders were not done. There is no living will. Advanced decision to refuse treatment was, okay, it's a no. Then the client does has a health care proxy, which is her son. Then, okay, the mental capacity, yes, it was assessed. The patient is just mentally stable. Then we look at the review systems. Vital signs, okay, temperature was 36.5 degrees. The BP was 106 over 68, pulse 97, the respirations 24. Then pain is okay, the pain score was 7 to 8 over 10. Totally confined to bed. So looking at other symptoms, we said, okay, the pain is severe, then there's mild dyspnea, anxiety, depression, and drowsiness. No vomiting reported. Then there's moderate anorexia, constipation. As we know, okay, as I stated earlier, that the client is on morphine. I think the morphine might be the reason he's constipated. He also has mild, okay, dry mouth and is confined to bed. Then focused investigation. And okay, there were no lab results that were there. I think the client lost some of the medical papers, but she's on ART, as we said, so it's HIV positive. Then looking at the further plan for this patient, okay, under the symptom control. One was the major concern is the pain, yes. And I think the dosage that the client is currently taking is not enough. It doesn't relieve her from the pain that she is feeling currently. So he was due for refill, the morphine refill, and I encourage her to notify the doctor or the nurse about the current dosage is taken so that they may increase the intake of the morphine. Then I also gave diclofenac just to supplement as I've stated that the cancer has progressed. It usually complains of back pain. So usually diclo will help with the bone pain, and also supplements such as calcium gluconate. And I also gave bisacodyne as a laxative, as he didn't have any. 5 milligrams 2 tabs Noctare. So, and also encourage the intake of warm fluids. Then I also gave multivitamin as he has loss of appetite, and I gave oral rehydration salts just to boost energy levels as well. But we also encourage the patient to buy vitamin D complex if we didn't have. Then another thing was the issue of family meeting. Yes, we did had a conversation with some of the family members that we did, but we also spotted the need to engage the family more. As I stated earlier, that some of the family members are still believing that she can get treatment traditionally, and that's against the will of the patient. So it's proper to engage everyone so that everyone can be on board on what's happening on this patient. So we're to discuss the end of life care with family members and to take them through the signs of end of life stage. Yeah, so that everyone will be aware of the patient condition, and to discuss the importance of family support in end of life care. Okay, one gap that I also noted was with the advanced care directives. I think there is more that needs to be done as well in terms of getting everyone on board of the patient wishes. So I think it's one thing that should be included in the family meeting. And also for support, so the patient and family members were encouraged to call the hospice team whenever they needed our support. So they do have our numbers. If ever they need us, they actually call us. And also to engage the patient spiritual advisor, church pastor, to continue support. I can say that the patient is being supported by the church members. So it's end of life, you really need that kind of support from the spirituality part of the patient. I think that's all about our case for today. Thank you for this.
Thank you, Seminele. Thank you very much for this. I would like to invite questions, concerns, and addition to what Seminele has presented to us about our case for today. What I've captured about this case is that the patient seemingly, or from the presentation, has accepted that he or she is ready to die, but the family, they are not ready to lose their loved one. So they now are trying to an alternative means of this patient to stay alive, which is traditional remedies. So, and what I got from the care plan there is a pastor, spiritual pastor for this patient, which is in plan. Yet the family wants traditional access, and there is some conflicts, traditional remedies and the pastor. So I think there's something that can be done in order for our patient here to go peaceful. And another thing I've noted, our patient is anorexia, which is one of the symptoms that was mentioned in our case, on our presentation participants, the decrease in oral intake, which means this patient is really indeed in transitioning to death. So thank you very much. I would like the floor to take on either a question or concern or an addition or an advice to the management of this patient. Thank you. Okay, everyone, you can still write on the chat box, or you can raise your hand. I will give us 3 minutes before we move on. Yes, I have Mr. Matamu here. Something.
Okay, thank you so much, Ibombo, for such a presentation. This is a wonderful case. That's presented a lot of needs, and that requires a lot of issues to be addressed. But maybe we can address a few questions that maybe I will require the Bongo to clarify for the team. Maybe we can then get the understanding. I've heard that the patient is on morphine, but I saw the pain score ranging 7-8. Maybe you can clarify how has the patient been taking the morphine, who is responsible to administer the morphine, because at 62 years old, they had written ECOG 4, meaning there's nothing the patient can do for self. Now it's totally dependent on the caregiver. So maybe he can clarify on the issue of how is the morphine being prescribed, how much is the patient taking? Because, and then I saw the issue of NSAID prescription. Is it that the patient has a bone pain, or what could be the indication of the dialogue for such a patient? I also saw calcium and the multivitamin. So I don't know if it's still beneficiary for such a patient. Maybe they clarify the issue if what could lead to the prescription of such supplements for this patient. And then the issue of the family meeting. I'm understanding that the family is said to be willing to go for traditional second opinion or treatment for. I want to know if how much has been the family involved in the care of the patient. Do they really understand the diagnosis itself? Was it explained to the family itself, if they are aware? And then the other thing is the issue of a proxy decision maker without advanced care planning or advanced decision to refuse treatment. If the patient was given the opportunity to make such statements or decisions, how has the patient taken that? Did the patient accepted or refused such conversation? Maybe if they can also clarify that. And then the issue is the issue of how has the family been involved before we even reach the stage of end of life, if ever. And then is the issue of the caregiver. Does this patient equal for, meaning totally bedridden, not able to feed himself or bath? Who is taking care of this patient? How much is the level of distress and suffering for this patient? Is a 62-year-old? Is this patient a widowed or married? Where are the children? Are they at home, or who is staying with the patient? And then is the issue, how long has the patient been on ECOP for? And then the other one is, how long has this patient been under our care or under the home-based palliative care? When was the patient referred to us? Maybe those things can help us to understand a lot more about this patient. Then we can ask. I have another one that I see on the chart by Patsy. In June, what was the patient? And the patient is another one that says in June, what was the patient's weight before receiving the chemo? And then another one. I see another one from Felicity. Thank you, team, for caring continuous. It is not easy for family to watch their loved ones starving to death. It is important to explain, no need to force means. Okay, he's coming with a solution to one of the issues being presented. I think those are the few questions maybe I will ask, maybe to clarify for the team to understand as we go.
Thank you so much, Mr. Matamu, for your questions, sir. And please that's it.
Wait.
Oh, okay. Let me start by a question on chat from, let's see. Well, I don't have the record of the weight before he did the chemotherapy. Yes, the client was referred to us from Babane Government Hospital, but at that time, he had not done any chemotherapy. So he was just a stable patient, EPOC 2. Okay, I don't have the specific dates on the referral dates, but it was last year. I think around June or even before June. So the weights, I don't know if the weights, how long. As to what was her weights, but as compared to her weight now, he has just lost so much weight. But I don't have the answer for, there was not any documents on or any report on the weight. Then coming to Mr. Mashamu's question, there were many questions he asked, but I will try to. So one of the questions was, how long was the patient under palliative care or under our care as a hospice team? Unfortunately, I don't have the answer to that as well, but I think it was around May, June, just around that before. Yeah, I think it was around May, June. Mr. Masham, last year. So then, how long has the patients have been bedridden? Okay, the patient has been bedridden for 3 months now. Has been in ECOG for about 3 months now. Otherwise, he was. When we took over, he was in ECOG 2. Then he later went to ECOG 3. in a space of, I think, 6 months or so. Then currently is an epoch 4, totally confined to bed. Okay, who takes care of the patient is it's head or time low usually, but there are other family members, such as her grandson, who are usually there to assist. But the main caregiver is the daughter-in-law for this patient. We usually communicate with her. He's the one that we always find when we go for home visits. Then the other question was, how is the family being involved in the care? Okay, the family is supportive, I would say, to the client or to the patient, but not everyone is supporting the patient. He does have, I'm not sure of the actual number of children he has, but I can recall that he does have 2 sons who are in South Africa, so they hardly see her, but they do come and they do call for support at times. Then the other question was the issue of the drugs, and if ever they are effective. Well, with the morphine, yes, that's why I say currently is taking 3 meals PO 6 hourly, and he has been taking that for about 3 months. It has been effective before. The patient wouldn't complain of severe pain because he was on morphine. So it was effective. I think now it's just maybe the body has become resistant to, I don't know what might be the cause of not being relieved by this dose now. So that's why I encouraged her, because it was due for refill. I encouraged her to notify the doctor or the nurses so that they may increase the dose of the morphine, with the hope that it will relieve her from the pain he's feeling currently. And with the issue of diclofenac, okay, he complained of the back pains, which was mainly on the bones. So I opted for diclo because it usually responds much better for the bone pain. I don't know whether it will help it, but I'm hoping we will see the progress as we do engage one another on the medications. And with the issue of the other supplements as well, I'm hoping that they will also relieve her from the symptoms he presented. We are trying to prevent to treat the symptoms that were said by the clients as well. I don't know whether I still answered or you are still lost, Mr. Madam.
I'm answered.
Thank you. Thank you, Seminary. We have Sister Felicity up on the chat box. Are there commodities you provided to the patient stroke family as a support?
Well, Sister, thank you for the question. Well, there are no commodities that we had to support the family. Okay, the patient complained of shortage of food, but unfortunately, when we conducted the home visits, we did not have any kind of food support that was in place in the organization. Otherwise, I feel like we still need to revisit the patients whenever we do have that kind of food support, which was one of the main things he indicated. Otherwise, the family members, they do support her in terms of finances, especially when he go for hospitalization. They are the one who usually take care of that. And I was communicating to one of the family members, actually the son who's the head care proxy, called me this morning. He was just asking a certain information about the client, because when I went there, he was not there. So he just wanted clarity, and I answered him. Thank you.
Thank you, Mr. Sibenele. We have another suggestion by Sister Felicity. Amitriptyline is 25 milligrams, ideal for pain involving nerve pain. Diastole has a tendency of worsening the gastritis. I think.
Thank you so much, Sister. Noted.
On another note, you can continue writing on the, okay, there is another by Petsile. I think the calcium and multivitamin were okay for what the patient complained about. Are there any fees to give to the patients?
Thank you, Petsile. I think I've answered that. Well, when we conducted the visit, we did not have any kind of food commodities in the organization. So once we do feel there is a need to go and revisit her for that kind of support. Thank you.
Okay, thank you, everyone. What I can add is just one thing that has been mentioned, in the chat box. It's about the family meeting. I think if it can be conducted, and I saw it in the federal care plan about, so that they can be on board with what the patient, they do the diagnosis of the patient and the prognosis. I don't think maybe there would be much panic from the family. So because they'll be understanding where the patient is at this stage and what are the changes we are needing to, since the patient herself, I saw there in the presentation that she has accepted that she's going to die now. Maybe it's probably by what Mr. Mahlangu said previously, the dreams, maybe we saw something that presented when I know this is the time for me to go. So seemingly he has accepted. And now I think the key thing is to bring the family members on board to the care of this patient so that they don't panic, and since they will cause some conflicts. The patient, I see the patient is a Christian, though it's not explicitly mentioned, but saying that is a spiritual advisor who is a pastor. So bringing the traditional remedies, I think, will conflict between the family members and the patient. So I think the family meeting will be very impact in the management of this patient, since we also notice now that the patient is at the end of life. So is transitioning to death. So yeah, and there is another check. Can the patient be advised to take blended smoothies? As I heard, she is a farmer by profession.
Noted, President.
Yes, thank you, Patsy. But at the same time, we can revisit the stages of end of life that the oral intake will be decreased. So she can be advised, but she cannot be forced to take them, as it won't help that much. That bit she can take, but not that is going to be of much gain since the patient's body is now shutting down. Any other comment or question? Mr. Manfano?
Maybe my addition would be that thank you so much for managing such a patient to this far. I think looking at when the patient was enrolled to palliative care to now, there's a lot that we could have done with the patient, and that the patient has lost functionality so much within the 3 months. And looking at the disease trajectory or the functionality status at this point in time, it signifies that death may happen at any time from now. Unfortunately, the patient gave us almost more than 9 months to address most of the issues, but now there's a lot that needs still to be done for the patient, but at a short time. That one may include the issue of total pain assessment, so that the patient has some anxiety, some depression, and some few things that may be contributed by the issue of severe pain. So I think if the issue of morphine education, it's required at this point in time. And the issue of what Patsy is saying, that the team involvement, so it's also required, especially here where the family is not in a team to support the patient. When one is supporting, another families are not. So there is a need to do some family involvement and meeting. And the fact that the spiritualities of the patient and the family are so different. The patient is accepting the prognosis of the disease, but the family is still looking for traditional modes. That may inform the information gap that might be between the healthcare team and the family and the patient. So I think one of the issues that were supposed to be addressed one at ECOP2 were the issues of the end of life, that should the treatment not work, A, B, C, D can happen. What will happen? That will push us to the level of advanced care plan, where the patient will then state that should that happen, this is what I will prefer. So I think that one also requires to be done to such patient. In fact, today's case is telling us that we don't need to wait until the worst happen like now. We need to discuss most of these topics we've been sharing in the previous session as early as possible. And then the issue I think we need to address also here is the issue of morphine titration. We understand that pain control may lead to a lot of problems. So I guess here the issue of the doctor, the social workers and staff must be involved, and the assessment of the patient. I mentioned during the exercise, I said that at the end of life, sometimes the pain would increase. And this one has an advanced disease. So advanced disease may include spinal compression. So we need to get such management. So with an advanced disease, pain will come in multiple sides and then disappear. So the issue of morphine monitoring and titration must be taken into consideration, and morphine education, how the morphine has to be taken. We don't know how the patient has been taking the morphine, that he may experience 7 to 8, which is severe pain at this time around with morphine. So I think that one needs to be considered and be checked. And the family must be educated and the patient must be educated that how to take it how to address issues of breakthrough pain with the available doses done now. And then I think the issue I've already stated is the issue of disease explanation, even with the family involvement. I think here the family is not clear of the disease pathology itself. What is it, what it happened, how it happens to be with this patient, and what is the prognosis. I think such issues must be discussed even as early as possible with the patient. So those are the things I would say the patient must be involved in. And then the issue of when we are discussing the issue of process decision making, I would advise that when we are going to discuss the issue of process decision making as early as possible, include the issues of advanced care treatment refusal and advanced care statement, so that they can guide you at this point in time that when these things have happened, how can the patient or to be taken care of. So maybe those things I will share today for such patients to be looked for. And at this point in time is the issue of family involvement. I see that as an elderly. When you know as an elder that your family is divided, that one also contributes to your pain. So I think the multidisciplinary or interdisciplinary team approach is required as soon as possible before the patient can pass on. That would be my addition maybe for this patient. Maybe for time's sake, let me also introduce that there is a feedback link that we have shared on chat. We may request you to click on it so you may share the feedback with us. This session marks the end of our series on communication and palliative care. Those who have been with us, they will remember that we started with palliative care itself, and then we look at ethics, then we treated the issue of communication. So may we take all the skills we've discussed in the past month of communication, then we move with them towards the next session will be on the 7th of September. We'll be looking at pain. So the next series will be tackling, it will be pain management. So may we request that all of us be available so that now we are going to apply both our ethics, our communications, and our understanding to palliative care into pain management and assessment. So that's what we'll be looking at in our next session. So on the 7th of September, we will be back and look at pain. We will look at pain, the principles of pain management under palliative care, and then we'll start that series and continue while we'll be doing that. So we'll start with the pain assessment and pain itself, then later we'll move to another theme, would be pain management. So thank you so much. That will be the announcement I have. We have the YouTube channel, Eswatini Hospice at Home. You can go and get that information from us. If ever you need, my presentations will be shared with you by emails. If you have not received, you can contact me. I will be able to share today's presentations with you. Thank you so much. Bye-bye. Thank you so much. Have a good day and see you in the next session.
Thank you, everyone. Have a great day.
Thank you.
Thank you, everyone. Have a great day.
Bye-bye. Thank you.
Bye-bye. So,